Can we have the PPT? I will.
Thank
just,
you.
Sure.
Dr. Suja.
Thank
One,
you. Yeah, anybody has any doubts, they can always get across to me. I'm
the
happy to
questions
help
are there
you.
in the chat box. If you can reply to them. So, Doctor.
Okay.
Thank
Okay.
you. So,
Thank you.
Yeah. So Dr. Raghavendra, this Monday he's with us. He's MBBS from BLDA Medical College, Bijapur, MD in anesthesiology from Bangalore Medical College and Research Institute, and DNB in critical care from Manipal Hospitals, Yeshwanthpur. Currently pursuing fellowship in ECMO by ECMO Society of India from Manipal Hospital, Old Airport Road, and cleared European Diploma in Critical Care Part 1. He has a vast experience in critical care medicine and a lot of skills in tele ICU, and also he has a lot of other certificate courses and research activities. Without taking much of your time, I'll hand over the session to Dr. Raghavendra for his expert comment and talk on management of hypertensive emergency. Over to you, Dr. Raghavendra.
Hi. Thank you, Dr. Sudhakar. Is my slide visible?
Yes, it's well visible.
Yes.
Yeah.
Okay. And thanks a lot for the previous speakers and my colleagues for elaborative discussion on the chest pain and the breathing difficulties. So without further delay, let us discuss on the management of the hypertensive emergency. So before I begin, we need to go with the terminologies. So what are the terminologies here? The hypertensive crisis is nothing but the severe elevation of your blood pressure that can have a potential to cause the target organ damage. It can be divided into hypertensive urgency, which is nothing but just a mere elevation of your blood pressures, but that has not caused any target organ damage. And the hypertensive emergency, which we will discuss in further slides, which is a condition where there's a severe elevation of your blood pressure that has already caused the organ damage. This can be your hypertensive encephalopathy, where one can find the altered mental status, cloudiness of the brain, or it could be accelerated malignant hypertensions, which can be visualized as a visual disturbances or the papilledema or the retinal exudates. So the thing is, why do we need to discuss on this hypertensive urgency or the emergency? It helps us in the triaging and further monitoring and providing the care to the patients, and also decides on when to intervene and to what extent we need to intervene. For example, not all the patients need to be intervened. Just mere increase in your blood pressure doesn't mean that we need to reduce the rapidly the blood pressures. So, and also how to intervene, whether we need to give the oral pills or through the IV medications. Therefore, that these terminologies are important in understanding the pathophysiology of the disease per se. Now, coming to the hypertensive emergency, it is nothing but the elevation of the blood pressures. In my previous slides, I have not mentioned the blood pressure targets. Okay, what is the increase in the blood pressures? Routinely, they say systolic should be more than 180 to define as a hypertensive urgency. But this is never the case in all the patients, because there will be individualized hypertension. For example, if the person is a chronic kidney disease, his blood pressures may be 230, systolic may be 230, but he may not be having any organ damage. Okay, it should be an individualized blood pressures. So hypertensive emergency is mere elevation of your severe blood pressures that is acute and that has led to organ damage. What are organ damage? For example, the person may have a pulmonary edema, may have a cardiac ischemia, may have an intracellular bleed or acute stroke, or have an acute kidney injury or aortic dissections, or can have an eclampsia. So blood pressure should be reduced. Definitely that should be our goal. How it can be reduced? Definitely, I don't believe in an individual person doing everything. It should always be a team role. ER physician plays an important role, ICU physician, cardiologist, nephrologist. Therefore, in any of the hypertensive emergencies, in its management, diagnosis, it is always a team's approach that always helps. What is etiology? Well, the most common cause will be the person will be diagnosed with the chronic hypertension and he might have missed the pills. He may not be compliant to the medications. That is the most common. Otherwise, the person may be taking certain medications that can increase his blood pressures. For example, a MAO inhibitors. So he may be increasing his blood pressures. Apart from that, if you find any person, any young individuals with raised blood pressures, we should always suspect some pheochromocytoma or adrenal gland problems. And apart from that, renal artery stenosis, for which we may have to do with the renal Doppler. Then he may be abusing certain medications like cocaine that can lead to increase in the blood pressures, and obviously preeclampsia. These are the etiologies that helps us in understanding the pathophysiology of the hypertensive emergencies. So if coming to a case scenarios, okay, so you're about to leave your hospital, you're going for some, you're planning for some other movies in the late evening, okay, suddenly a patient comes to you, okay, and the nurse calls you, doctor, there is an emergency here, a person is having high blood pressures, I need your attention. So what would be your reactions? This would be my reactions, definitely. So anyway, so we discuss here by case basis, a 75-year-old male patients with the known chronic kidney disease stage 1, non-oliguric, with hypertension and diabetes comes to your hospital with elevation of your blood pressures. How would you evaluate? Before evaluation, we need to have a history and physical examination. How the patients with hypertension emergency presents? Definitely they will have a headache, dizziness, altered mental status. They may have a difficulty in chest pain, breathing difficulty, and reduced urine output, and vision loss or the blurring of visions. These are the most common findings which we find in a patient with elevated blood pressures. So our patient had chest pain with shortness of breath with reduced urine output. We can see that there is an end organ damage with both lung and the urine system, and maybe possibility that the cardiac system may be involved. So this this defines as a hypertensive emergency. So on further evaluation, further examination, the person is noted to have a hypoxia on room air, tachypnea, mild tachycardia, elevated blood pressures, bilateral pedal edema. There is elevation of your lactates. Lactates are the markers that tells us about the tissue hypoperfusions. That is, the tissues are having less nutrients, and the bilateral crepitations are hurt. Most importantly, on further digging of history, we get to know that the person might have missed medications, hypertensive medications since a week. So how do we evaluate further? We definitely go with the complete blood count. We find that there is an anemia probably due to chronic disease. And the renal panel shows that elevation of your creatinine, urea, he may be having acute on chronic disease with hyponatremia, volume old states. And increased BNP levels, brain natriuretic peptide, these are usually find elevated in the when there is a stress to the myocardium. Dr. Sudhakar will let you know in detail about it. And further serial evaluations of tropoid comes to be normal. And apart from that, what we do the routine ECG evaluations. Evaluation may show that non-specific changes. Definitely, you can see here there is an LVH, concentric LVH. Then echo is an important findings, important parameter that has to be done bedside in any acute hypertensive emergency patients. The person may be having elevated LV end diastolic pressures. There may be a systolic dysfunctions, reduced contractility. So our patient may have a elevated and diastolic pressures. Apart from that, we have to get the X-ray done. This is typical finding of your battering appearance, which is usually seen in pulmonary edema. And one more important finding, one more important investigation that we have to do on bedside is ultrasound. Point of care ultrasound, where we find the B lines here, which is evident of your pulmonary edema. And our patient still has breathing difficulty and the chest pain. Why? Because we have not managed, we have not started the management yet. So always, what is the target? Our prime target is to reduce the blood pressure. How? It should be reduced by 20 to 25% of mean arterial pressure in first 1 to 2 hours. Apart from that, how do we approach? Whether it is always a team approach. And before that, we need to see the patients, how is the condition of the patients, which we usually go by ABCD approach. Most of the ER physicians, most of the ICU physicians will use this in acute crisis management. A stands for definitely an airway. If needed, we have to intubate the patient and put him on the ventilator. Our patient presently may not be needing the ventilator. Therefore, timely and regular assessment of the patients may help us, may warrant us, may tell us the recognition that the person is having impending airway, therefore may be needed intubations. Therefore, always do not hesitate to intubate if needed. Breathing, definitely our patient has a high respiratory rate, which can be, and reduced oxygenation, which can be supported by your non-invasive ventilations. It can be continuous positive airway pressure or high flow nasal cannula. By doing this, I will reduce the work of breathing and also I will increase the oxygen levels. Therefore, our patient needs positive and expiratory pressures. PEEP is nothing but it helps us in reduction in the pulmonary edema, that is presence of the water in the alveoli. Okay. So circulation, coming to the circulation, our patient had tachycardia, high blood pressures. How do we reduce? Yes, definitely this patient needs IV medications. For all the listeners, I would say that it is very impossible for us to remember the each and every doses. I always, during my rounds, I always see the guidelines or see the medication charts. So routinely we use the beta blockers, that is labetalol in our ICU, or the nitroglycerin. So this is the medications, these are the drug dosings that every listener has to go through it. If in doubt, please check. With the advent of your internet, or now it is AI mod era, you have to go with that. So for our patients, we have also started on injection furosemide. Apart from that, as discussed earlier, the D stands for the assessment of the mentations, like your Glasgow Coma scale or the mental status. If in any point of time, if the person has reduction in the mental status, reduction in the GCS levels, that is Glasgow Coma scale, if the score is less than 8, please intubate. Do not hesitate in intubations. Now, with patient also has the background of chronic kidney disease. Now the person has an acute pulmonary edema, maybe having a fluid overload, acute on chronic disease. What more we have left is the dialysis. This discretion should be done after detailed discussion with the nephrology team. So if the what kind of dialysis is needed, what sort of fluids have to be removed, it is again dependent on the discussion, should be discussed with the nephrology team and done accordingly. So by doing this, what we not only control the blood pressures, but we also reduce the fluid in the alveoli, that is nothing but your pulmonary edema. So we are not done yet, because after 24 to 48 hours, the blood pressure will be reduced, will have to be reduced. And then medical reconciliation is most important thing. How it can be done? What is that to be done? When there is the reduction in the IV flow, it can be done by the changes in the IV medications to the oral medications with the consent with the cardiology team, and the cardiology team will prescribe most of these medications based on the condition of the patient. For example, in our case, who has an acute kidney injuries, AS inhibitors and the ARBs will be more detrimental. So it is again has to be discussed with the cardiologist. And regular follow-up with the patients, timely monitoring of his blood pressures, and monitoring the target organ damage. And with every follow-up, we need to readjust the blood pressure medications and other supportive medications based on his clinical conditions. We are still not done yet, because the patient education is prime importance. We should emphasize them, that help them understand the hypertension, the ill effects of it. By educating them, we should use the language that is very simple, like using the lungs, high blood pressures, that it can damage your lungs, heart, etc. Emphasize the immediate medical attentions in emergency. If the patient has certain problems that could, like for example, this patient had a difficulty in breathing, that patient needs to be attended by medical professionals. Apart from that, the patient should be emphasized on the strict adherence to the medical prescribed medications, explain how stopping of the medications would lead to certain repercussions and the complications. And lifestyle medications, like lifestyle changes, like using dietary habits, like using vegetables, restriction of diets, fruits, promoting regular and physical exercises like walking, doing yoga, pranayama, swimming, etc. At least 30 hours in most of the days, 30 minutes in most of the weeks is important. To summarize, definitely we need to understand what exactly the hypertensive crisis or emergency is. We need to recognize the immediate warning signs, triage them, monitor and treat accordingly. Our primary goal should be reduction of the blood pressures, but also to prevent its complications by timely monitoring the patients and giving the medications. And always, as in my previous slides, I have reiterated the fact that it is always a team approach. Each and every individual plays an important role. And last but not the least, regular follow-up of the patients and patient education remains the prime importance. Thank you. Any questions?
Thank you, Dr. Raghavendra, for such a elaborate talk. I think because we have finished very short of time. I think one question which came to in hypertensive urgency as well, labetalol and nitroprusside use. And are there any difference in medication use in hypertensive emergency and urgency?
See, urgency, it means that the urgency, it is we don't have to jump in suddenly. The medications may be needed, but if in case of emergency, definitely we have to, it is like timely reduction of the blood pressures. In urgency, if the person is not having any end organ damage, we can also go with the oral medications. I feel you are the better person to be spoken about that. But in emergency, definitely IV medications and the rapid reduction of the blood pressures, that to 25% of the MAP in first 2 hours warrants it, so as to prevent the further organ damage.
Right. Thank you once again, Dr. Raghavendra, for elaborate talk. And I think it was a very important talk. I think few important questions, if you're free in next few minutes, you can just answer in the chat box.
Definitely. Thank you. Thanks a lot.
Thank you once again. So I think I'll move on to the next session. The next session is by Dr. Harsha Sagar on management of acute heart failure. Dr. M. Harsha Sagar has done his MD General Medicine from Kasturba Medical College, Mangalore, and DM Cardiology from Kasturba Medical College, Manipal. He is a recipient of gold medal in DM Cardiology, Dr. Late Arun Guzgal Award in DM Cardiology, gold medal, best outgoing student in DM Cardiology, Dr. KP Ganesan, Dr. BM Hegde, and Dr. Prabhakar Rao